Hi, I'm Dr. Rachel Tate coming to you from RWCS 2019, and I'm with Dr. LaSyone, who's going to tell us about one of his interesting cases. And I think there are a lot of salient points to this, and I'm really glad you brought this case for us, Lucas.
Thank you. So my case, I wanted to highlight because although there's not super interesting features necessarily that differentiate it, it's a really classic case that we should always kind of think about on the differential when we see a patient with sclerodactyly or indurated skin. So this is a 55-year-old gentleman that initially came into the emergency department over the summer. That time was complaining of some neuropathic pain, nerve pain shooting down into his hands and feet, some chest pain. The team then checked a CK, they did a cardiac workup. He was essentially discharged home. When we actually got called was about 3 months later, so this is in October. At that time, again, still having the nerve pain described as shooting down from kind of forearms into the hands and from backs of the legs down into the feet. But then interestingly, he asked me specifically, "Doctor, why is my skin so thick?" And so when we were looking at the skin, you could see the pathology very firm and indurated. But he also sort of held up his arm and said, "Why does my arm do this?" demonstrating his, what you see in the pictures is his very classic groove sign and peau d'orange changes. Notably, no Raynaud's, no rashes, no weakness, normal nail fold capillaroscopy. And then if you looked at his labs, actually going back to the summer, he had a peripheral eosinophilia that had previously been missed. So we were very concerned at that point, even without the MRI, sort of our leading diagnosis with the classic skin changes, and even his neuropathy for eosinophilic fasciitis. And even before the biopsy, the MRI actually kind of clinched the diagnosis. Very classic findings of essentially fascial enhancement that actually extend into the intermuscular planes, but without any surrounding myositis. And so I know at some centers actually, because one of our attendings did a lot of the scleroderma research at UCLA, and one of his partners in that field on the East Coast actually just used the skin findings and an MRI to make the diagnosis. But since it was such an interesting case for us and we don't see that many come through, we decided to pursue the full thickness biopsy.
What I think is really interesting about this is that sometimes we miss the diagnosis. And to be fair, the team that saw him initially thought it was a cardiovascular issue. And of course, in the emergency room, we have to focus on the things that can kill a patient. But what's interesting, and you pointed this out, Lucas, is that he had a peripheral eosinophilia even then. So the question really becomes, had he been more apt to follow up, maybe, some other conditions I'm sure played a factor, then maybe we would have had a diagnosis sooner. But you told me an interesting thing about this case too, that the patient now is doing well. What did you do for him? Tell me about that.
So, and again, not much literature in terms of directing us for treatment. But the larger case series, like 10 or 15 patients, when I say large, essentially first line is prednisone. And from that data as well, it kind of suggests, again, the number of patients is quite small, that most patients are not going to have a complete response to prednisone alone. And so typically sort of the first line, again, as in most of our diseases, is to add methotrexate as a steroid-sparing agent. The thing to keep in mind is the literature for patients who do respond may not see a response for 18, 24 months. And so your goal with treatment is not so much in the short term to get the skin better, but it's to prevent it from getting worse. And so a big part of that is preventing joint contractures. The patients historically who did poorly actually ended up with a lot of morbidity related to the joint contractures. And so the steroids and the methotrexate, as well as help from our physical therapists and occupational therapists, is really to prevent that morbidity, even if we can't get a complete response in the skin.
Well, I think this is a great case. It's one more for the books, especially since we don't have a huge patient population. Thank you for coming, Dr. LaSyone. I really appreciate it. And more from Rheumnow.com, and continue to check us out at RWCS 2019.